how do we decide which CHF patients are we going to admit versus discharge? Do you want me to?
You start.
Okay.
That's a good one.
This is a diabolically tough question, and it's got a lot of different factors. I do use ultrasound for this. I think that if I'm seeing something new, if I do my bedside echo and you look way different than that last echo that's in the chart, I'm probably going to admit you. If you're new onset, I'm definitely admitting you. But the single best test that I like to use for this is the rolling O2 sat. So before you're sending someone home with any complaint that could be read as dyspnea, this could be an asthmatic, this could be congestive heart failure, this could be pulmonary hypertension, you pick it. I like to have them walk and see what their SATs are. Now, traditionally, the patient would actually walk around with a pulse ox on their finger, and you would sit there and stare and watch at it. That's actually a little clunky, because usually the nurse has to go get another machine and all this other stuff. I'm pretty comfortable saying, we're going to have you walk around with whatever oxygen level you were supposed to be at home, which is often room air, and I'm going to make the nurse take you a couple trips around the ER. And then we're going to sit you down and check what your pulse ox is. And if that number is less than 88, you need to come in because you need oxygen. And I can't discharge you with oxygen. So I think that's a very, very good-looking test to have on your chart, because you're actually showing them in a physiologic way that, yes, I think that you can walk to the kitchen and back without desatting when I send you home. But it picks up on surprising folks. You'd be shocked at the number of asthmatics that are just sitting there and they got these so-so oxygen sats. Then you walk them around and realize they have no exercise tolerance at all. And not only should I not discharge this patient, they may be too sick for the floor. So I've been humbled quite a few times with the rolling O2 sat.
I think that it is a complex issue, and I think that us not having a dedicated CHF service does some disservice to our patients, because there are a lot of interventions that should be done on patients with CHF that don't necessarily get done unless you have a CHF service. So, you got somebody that comes in, they're short of breath. I get them up, I walk them like Dan says. I ask them, do you feel back to normal? Do you feel back to close to normal? Do you think you can handle it? So I use a lot of subjective measures of how they feel. But then, you send them home and their creatinine was 1.4, and now, 2 days later it's 1.8. That's a fair bit of loss in renal function. It's because you've dried them out, you've caused them, decreased blood flow to their kidneys, so now their kidneys are getting ischemic. So, I think that then is more of a reason, especially if you've seen it in the past, to be more liberal in admitting them and letting the cardiologist take a look at them so they can get them on better blood pressure control medicines and those kind of things.
But I think those follow-up instructions are so key. These folks are very high risk. It's a dynamic disease that changes not just on a day-by-day but hourly basis. And so these types of diseases are really, really tough to manage, and you need to give them big, scary discharge instructions. They need to know, even if they were here today, that they need to come back tomorrow if things get worse, if their weight kicks up several pounds, something like that.
I have one more thing after this.
Sure, yeah.
I was going to say, also be wary of some of the medicine folks and the cards will push back sometimes, say, oh, they were just admitted 2 weeks ago, same kind of thing, up their dose or whatever, and get them out of here. But there's a reason they came back, and a lot of those folks are because they live alone, they're not taking their meds right, anything else, and there was a discussion at some point about putting them in an assisted living or whatever else. Maybe they don't have family there, maybe the family shows up this time, but placement issues need to be discussed. And if you mention that when you're trying to admit them, I think that helps a lot, and I think it does the patient a better service, because that way they don't come back. They're not missing their doses of whatever it is, and they're getting put where they need to go.
So thank you, Daryl, for bringing up social admits with 30 seconds left in our lecture. I very much, you bring up a great point. Often these are not very sexy admissions to the inpatient services, because it's pretty boring for them. They're like, oh, we checked your weight and gave you the furosemide, and we just watched you slowly get better. But I think that's where that rolling O2 sat really helps you. If they desat on that, end of discussion. Like, no one in their right mind is saying that I think that we should discharge a hypoxic patient. Like, you really want to come down and put that in the chart? They're not going to do it. So it really helps. And if they pass that test, if they show that they can walk around with no chest pain and maintain their SATs, then I think the inpatient teams have a little bit of a point of, is there a way that we can stretch this patient out by tweaking their meds and so forth and save an admission? There's going to be a lot of pressure with upcoming and active healthcare regulation about what it means to be admitted to the hospital what it means to bounce back within X number of hours or days, and how that's going to affect the hospital. And unfortunately, a big part of that decision to admit or not is on us. And so these other services are going to look to us more and more about making very aggressive dispositions and sending people home that we didn't used to send home. And that's going to be the new reality in upcoming years.